All right, well, we can go ahead and get started. And Aaron, do you guys want to start since you had some slides to go through?
Sure. Let
Then
me,
maybe we
oh
can
no,
go.
it's not letting me share.
Okay. I can share my desktop here, and you can just tell me when to
Okay. That
slides.
works.
I'll be your presentation clicker. Okay. Can folks see the presentation here?
Yeah, I can see it. All right. So I'm Erin Finn. I'm one of the POCUS the co-directors of our curriculum for at UNC with Dr. Ria Dancel. So I was just going to briefly tell you guys about what we're doing at UNC. We call it the basal bolus curriculum. I have done a version on the pediatric side, and I'm hoping to implement this more on pediatrics, but just as a disclaimer, this curriculum itself is mostly on for our internal medicine residents and med peds residents. Okay, next slide. So we call it basal bolus curriculum because of the idea of insulin basal bolus. But with our POCUS education, unlike with insulin, where you don't want to stack, our goal is really to stack the education over the few years of residency. So our basal component includes an intern longitudinal curriculum, which is mandatory for all of our categorical residents. And so they have courses every 6 weeks or so throughout the entire year. And then over the next 2 to 3 years, the goal is to have more and more boluses of POCUS education over that time to try and just add to that basal amount that we gave them earlier. So that includes a 2-week elective that's offered 6 times throughout the year that the majority of residents participate in. Also scanning in the ICUs. We have a procedure service that all the residents rotate through. And then also we ask our residents to come back and teach in the intern curriculum, which helps us with having more educators, but also reinforces knowledge that we've taught. We help with presenting noon conferences and morning reports. And then we have a WhatsApp POCUS teaching cases chat that I'll talk a little bit about in a few slides. Next. So these are the core POCUS applications that we focus on. And I adjusted this a little bit for pediatrics, but it's basically very similar. And so over both the longitudinal curriculum and then the elective curriculum, this is what we try to cover. So we start with abdomen, then lung and pleura, vascular. We split cardiac into two separate sessions. Then we focus on some procedural POCUS and MSK. And then we finish up with some simulations and clinical integration. And for the longitudinal curriculum, so the basal component, we have a pre-test that's clinical integration and knowledge assessment, and then we repeat that at the end. And then for our elective, we have them do that pre and post test, and we also have a hands-on skills assessment. Next. So the longitudinal curriculum, which is our basal component, this is kind of the design. I always send out videos before we meet with the residents. It's questionable how many of them actually watch the videos, which is fine because when we meet in person, we do a 30-minute didactic followed by about an hour of hands-on teaching and then an hour of abnormal image review where we have abnormal POCUS images and we have the residents systematically interpret them so they can learn to identify abnormal images as well as artifacts and pitfalls. Next slide. This is what our hands-on and didactics looks like. We started this during COVID, so you can see everyone's wearing shields and masks. But you can see also back then we used both cart-based machines and handheld machines. Those are also our residents that are posing. So our models for the hands-on are all volunteers of the residents who are also scanning, and then they'll kind of flip-flop with each other. Next. The elective, which is a major part of the bolus part of our curriculum, is offered 6 times throughout the year. It's mostly just run by myself and Dr. Dancel. It starts with a 2-day intensive boot camp where we cover everything, all those core components that I mentioned earlier, and everything that we've taught during intern year, we reteach that in 2 very intense days. And then we have a 2-week consult service, which I'll talk about in a second. And then sprinkled in throughout those 2 weeks, we have some procedural education. We go over some evidence based medicine, and then there's also opportunities to rotate with the sports med and rheumatology clinics. Next slide. This is what our kind of the format for our consult service. We have a pager, which it looks like I was signed in on at this time. But the residents in the morning hold the pager. They can get consults from anyone in the hospital. They'll go by themselves and go obtain images on patients, often have to struggle a bit, and then kind of make some interpretations. We see them, we as the POCUS faculty, will go back in the afternoon and they'll show us all of our images. We'll talk about them, we'll do some teaching, and then often we'll go back to the bedside, maybe improve some of the images, but do some bedside teaching, clinical integration, and then we'll go back to the primary teams and give them kind of our recommendations after the fact. Next. Sometimes, so the goal really is that they get their hands on the ultrasound and scanning real patients. So sometimes if they're not getting consults, there's other ways that we'll have them go scan patients. This was funny. The last elective we had, our Med Peds program director, Mike Connorino, had just come back from a ski trip and had some rib pain. So he came and got his own consult, which showed that he had a rib fracture. Next slide. These are some of the boluses that I talked about. In addition to the elective, we will work with the residents to do noon conferences and morning reports. So you can see this is Rhea down here with one of the residents. We also do trivia and Jeopardy. And then the POCUS WhatsApp, I think, is one of the big components of our curriculum that is really helpful. It's just this, obviously, WhatsApp group messaging chain, and we have probably hundreds of residents who are on it now, but it started a few years ago. And it's a place that the residents can share de-identified clips so that they can have feedback on how they can improve their clip, also how they can interpret those images and clinical integration. It's also a place that we'll just do some teaching. So we'll present a case and have the residents work through it. There's several faculty on there who offer feedback, and depending on what time it is, there's usually one of us is awake, even if it's in the middle of the night. And what's also neat is since we started this a few years ago, the residents who started with us have stayed on, and many of them are fellows in cardiology, rheumatology, pulmonology, et cetera. And they'll also offer some really great feedback and help with clinical integration. Next slide. And then for procedural training, so on the medicine side, we have a dedicated procedure service. We don't have one yet on pediatrics. We're trying to create one, but a lot of the proceduralists on medicine are Med Peds trained. And so we'll do plenty of ultrasound guided procedures on the pediatric side. So these are kind of the procedures I try to focus on when teaching our pediatrics residents. Next slide. Here's some PIV training. There's some brave residents who are putting ultrasound guided IVs in on themselves, but here I'm demonstrating that you can also just do it on a vessel trainer. Next slide. Lumbar punctures are huge. So we do lots of ultrasound assisted lumbar punctures on the pediatric side. This is my daughter who I was scanning, but right here, here's an ultrasound clip of her spine. So these are the spinous processes. Down here, you can see her conus, and then black above here is fluid, and then the cauda equina. So very helpful for planning lumbar punctures. Next slide. And then bladder ultrasound is really helpful too when you're thinking about working up a febrile newborn. Knowing how to ultrasound the bladder can be helpful to ensure that when you catheterize them, you actually get urine. Next slide. In terms of access to ultrasounds, we have some dedicated teaching machines that on the medicine side that we can borrow for pediatrics teaching, but we also have some in the sim center that in our sim center that we're lucky enough to use. There's a few pocket ultrasounds available on the wards, and then we have some that we'll borrow from the ICU or the EDs, and a procedural ultrasound on the pediatric floors. Next slide. I mentioned this already, our WhatsApp, but this is just an example of one of the cases that we had. This was scanning a patient with back pain after a renal biopsy and found a hemorrhage. And so that's what we are showing the residents there. Next slide. In terms of who's teaching with us, UNC has a very strong Med Peds presence. So a lot of the educators are Med Peds. So they'll teach both on the medicine and the pediatric side, which is helpful, but it's also very multidisciplinary. So we have our sports med colleagues that'll help teach rheumatology, family med, peds emergency, nephrology, pulm crit. And then I think one of the most helpful instructors is Ron Wofford from our cardiology department. He's one of our echo techs, and he always teaches during our elective and is really, really helpful. That's my last slide, I think. So that is a very quick introduction to what we're doing at UNC. I'm happy to answer questions later and answer questions in the chat or whatever is helpful.
Yeah, awesome. I wrote down a few things to to get to and ask you about a little bit later, but we can move on to the next group. Doctors Tony and Brandon, are you guys ready to talk?
Yes, sure.
Cool.
I was
I
just
think
wondering if I could share my
Yeah.
screen. I sent a request. I'm not sure if that will work.
I just agreed to it, so let's see.
Okay. Great presentation, Erin. I'm not as organized as you are today, but I'll introduce myself and Dr. Julia Brandt can also introduce herself as well. I am the Peds Emergency Ultrasound Director at Denver Health, which is sort of the inner city hospital that has both a Peds side to their ED that's about 19 beds, and then the adult side is, I don't know, about 60 beds or so. But I am Pam Malone and only really clinically work in the Peds ER, and then we'll scan anywhere, if you will. But I trained at Children's, and actually Julia was one of our pediatrician POCUS fellows back in the day. So we were doing the project together, creating a curriculum for Peds residents at Denver Health. So I trained at Children's and then came over to Denver Health, but Julia, you can introduce yourself as well.
Yeah, thanks, Amanda. Amanda was my ultrasound fellowship director, which is great. So now I've done, I guess, my second fellowship. So I did do a PEM fellowship. Ultimately, I'm the co-director of the PEM fellow of the ultrasound and the ED there, and I run our PEM fellow curriculum. And Amanda really is the brains and the designer behind the Peds residency, which is why I wanted to invite her. We did do some work when I was her fellow, and developing the third year curriculum. We sort of made it more longitudinal. Amanda does now I think all of the residency, but at the time was really focused on the intern side. And then I kind of helped with the second and third years. And so it was a great collaboration since I'm at the Children's Hospital, which is across town and like sort of the academic Ivy League or Ivy, it's like the gold, whatever Ivory Tower, that's what I'm thinking of, the Ivory Tower Hospital. But as Amanda said, we kind of both residents rotate at both hospitals. So they rotate both at Children's and they rotate at Denver Health, and they get kind of experience on the wards and the ICU and the ED and all the specialties in both hospitals.
And, just working at Denver Health too, I did my POCUS fellowship here at Denver Health. And, we were using very little POCUS in the Children's Colorado ED. And obviously now they're champions of POCUS there. But when I was training, they really didn't have anything. Came over to Denver Health, did my POCUS fellowship. And then also just saw such a disparity when we had our emergency medicine residents working right next to our pediatric residents in our ED. Emergency medicine got a fair amount of POCUS, peds got nothing. And then they'd be asked, well, go assess for the intrauterine pregnancy. And, their eyeballs would pop out of their heads. So such a disparity between training for the two different residency groups. So actually, I was looking up the date. In 2017, we created a PEDS intern POCUS curriculum at Denver Health, but it's the same pediatric residents who rotate at Children's, and one of their sites is Denver Health. So we worked together with some POCUS experts at that point over at Children's, and we sat down. And one of the questions was, how did you get buy-in from the POCUS directors? So, excuse me, from the program directors, from the PEDS program directors. So we kind of sat down and as a group of more, POCUS focused people and talked to the program directors. And I think it was mostly assistant program directors in this meeting, and said, like, we really need to do this. Our PEDS residents are really at a disadvantage. And the perfect example was the emergency department. And they were pretty easily convinced. And we actually started the program in 2017. And the start of the program was for interns. So they actually were okay with us. This is kind of a breakdown of years in terms of what the curriculum was. Initially was just our first year curriculum, in which we actually had all residents, pediatric residents, roughly 30-ish residents, go through the curriculum, which included these topics. We kind of decided or just kind of brainstormed what we thought would be most useful at both sites at that point of view, with probably our soft tissue MSK being the highest yield that we use in our emergency department. So just trying to be focused on our centers and what applications we thought would be appropriate. And the program directors kind of bought on, and we were allowed, basically the groups were broken into 3 different groups. And we had each intern had 3 half-day sessions of POCUS throughout their first year, which went over these topics. And then as we kind of expanded the program, the children's did the second and third year. And these were, Julia, they added on kind of 1 to 2 hour lectures throughout their academic schedule throughout their second and third year. So sort of like refreshers, but it was sort of shorter lecture based. And then Julia, during her fellowship, created the optional third year elective. And I'll let you describe that, Julia.
Yeah, so as you can imagine, like the hands-on piece is most important, I think, and they really had some refreshers, but not hands-on. So the third year, we identified residents who were interested in having POCUS as part of their career, or potentially even interested. And so what I did was basically, because I had done my fellowship at that time, half at Denver Health and half at Children, so I knew a lot of the faculty. So one of the questions I know was how do you decide who's qualified to teach? So a lot of it is people who are already trained that we knew, or because people that I had worked with in my fellowship. And so basically I sort of set it up the way I had set up. I sort of set up my own fellowship at the Children's half. Like I managed all of mine at Denver Health, but I sort of pursued it all on my own at Children's, and basically hunted down like every, ultrasound tech I could talk to. I worked with the head of radiology and ultrasound. I worked with the cardiologists, and the echo lab. The echo tech, as you mentioned, was super, super, super helpful for me. And so I set up all that. So they basically had half-day experiences over 2 weeks that they got to do with all these different fields. So we taught, so the ultrasound faculty who are credentialed in the emergency department, and then we have a PICU and a PICU hospitalist, and then a hospitalist who teach. And so we all picked different topics and sort of made a list ahead of time what we wanted to cover based on kind of what we did in our first year. And then either they scanned with the echosonographers or the ultrasound techs, or they scanned with one of us. And we sort of did a lot, mostly just almost all entirely straight hands. They did a lot of asynchronous learning, so they had things I had to look at and to try to read. I don't know if they actually did. I think I asked them if they did, and they said they did, but it's residency. But for the most part, they scanned, which was great. And so we basically they had basically 10 full days of like all day at the hospital scanning with some person or another, which was really, I think, a really good experience.
Right. And we have revamped the intern process a little bit, because I can show you, this is Julia's paper that gives you the results. We studied almost about 50 Peds residents who went through the intern curriculum, and they all showed, we studied them with written exams. They showed improvement in written exams. They showed pretty good proficiency at the end of the year with their OSCE exam as well. And the survey, like 89% of the 49 residents said it was like very effective education. However, we did ask them to say, how many scans are you doing outside of these educational sessions? And it was like less than 5 scans done over a year outside of the educational sessions. So we have revamped it this year, trying to make it a little bit more interactive. So we do each didactic session involves like case-based learning, where we have a case and then you have to scan your colleague, case, scan your colleague. So those are the first 2 sessions in which we teach EFAST and the approach to the patient, like shortness of breath or in shock, like a rush exam. And then we just started going into our 3rd session back into the ED and scanning peds and adults, trying to get more hands-on scanning on actual patients. So we're studying that as well. But our biggest struggle, like one of the questions that was proposed to us, like, how do we have these peds residents do more actual scans on patients? So that's definitely our huge barrier, I would say. In both of our institutions where our residents rotate, I would say the emergency medicine providers are comfortable, or PICU are comfortable, and a handful of some of the hospitalists are comfortable as well. And I think, Julia, you guys are working with the hospitalists over at Children's. Maybe you can speak to that as well, how to get more. I think more attendings have to be comfortable in order for the residents to do it. So we have gotten in trouble at our institution that one resident actually diagnosed gallstones overnight. The resident was correct, but there was the attending wasn't aware that they were actually ultrasounding. So it became a big to-do. So we messaged that, like, you just need to get us in the emergency department. It's pretty mainstream now, right? So, but if you're and PICU is pretty mainstream, but if you're on the wards, you need to get approval from your supervisor attending to do the study, because it varies with comfort level and whether they're truly like sort of permitted to scan, which is one of our big barriers. Julie, could you speak to the program with the hospitalists over at Children's Colorado?
Yeah, I think again, it's still kind of in its infancy a little bit. Like they have a very strong lead at the hospitalist program who is working on it. He also is med peds trained. Actually both of us went to UNC for med school, so I was like, he's one of our faculty that works on this. And I think it's just we've gotten more buy-in now that some of the older faculty, I think, have stepped down from leadership roles. We had some really big roadblocks initially from our CMO, who was director of safety before that. And he was really he was a hospitalist, really anti-using like scanning on the wards because we felt like we weren't credentialed. But now, we've formed a hospital-wide committee. That's our big thing. I mean, I said like it's really hard just to get the resident because the residents even in the ED sometimes are very uninterested in the ED, like which is obviously my passion because they want to do like genetics, right? And so they have no interest in emergency medicine, which I understand, but it's really hard sometimes to get them to commit to anything. I think the same is true for POCUS, where if they don't see themselves using it, it's really hard for them to kind of continue it beyond the sessions that they're required to, that they're required to do as part of their residency. And I think so hospital medicine, because there's so much hospital, like we're very, very inpatient heavy in our residency. I think that's becoming a little bit more less of a barrier now that these people have stepped down to go back to that. And now that more specialists, we have like anesthesia, we have sports medicine, we have pulmonology, we have hematology, we have all of these fields now that are using point-of-care ultrasound for certain things. And so that's becoming more, I think, prominent. So the residents are really, there's more interest. And so I think that that is now, because we're a hospital-wide committee, we are now getting middleware for the whole hospital. We are streamlining everything and trying to have like specific things that can go across different fields. I think it's become a little bit more successful for the hospitalists. They actually are going to be now credentialed. Like we're the first department to be credentialed, and then they pick you, and then now NICU and hospital medicine, and then they can all bill. And so then the billing makes the hospital realize, oh, we can make money off of this. And so then now the hospital is interested in pushing for this credentialing. So I think it will expand, and that's what we're seeing. It has just taken like a decade.
Another intervention we did try was at one time we had smaller groups. We're back to bigger groups based on what the pediatric residency needs in terms of organizing their other educational activities. So now we have bigger groups, but at one time we had small groups, especially during COVID. And we gave everyone, we were able to give everyone a butterfly per rotation. And we thought, well, maybe this would increase the amount of scans they're doing outside of our sessions. And it was like a big failure. There was a few, even some scans done on their dogs, etc. But it was not, did not improve those numbers that done outside of sessions.
Yeah, I feel like once we get the other specialties on board, it's like I feel like that will help. That's sort of my thought is now that we're using it more like across the hospital specialties, it's pushing the residents a little bit more. Like I see more interest, but it has been like that continuity or longitudinalness has been really hard to sort of push.
Yeah, we've only done evaluations like beginning of intern year, end of intern year. We haven't evaluated beginning of intern year, end of third year. We've added a few other things such as orientation. So we're doing a POCUS orientation for our rising third year Peds residents, and that will be in a week's time to really try to improve skills for their third year rotations, which does include being like have a lot of autonomy in our pediatric ED at Denver Health. So we are starting like doing those POCUS orientations, kind of refreshers, if you will. Those have been sort of on and off. It hasn't been steady in our 3-year curriculum, but hopefully we hope to make that more permanent.
Awesome. Yeah, certainly interesting but not unique challenges. I think a lot of people can probably relate to some of the things that you brought up, and I think I definitely relate to that notion of you're trying to make it easy enough for the residents to sort of hit that threshold where they feel confident and they get maybe some easy wins up front as far as like identifying pathology and feeling like they're really integrating it clinically. But then you're it's just sort of hard if people aren't intrinsically motivated to do it. Sometimes you can't force them. Yeah, awesome. There was one comment: taking discomfort can be a big barrier. So we're addressing that. Yeah, and that's a thing that we hear a lot too, is just trying to hit critical mass with supervisors because the residents want to do it, but their attending either isn't comfortable or doesn't know how to supervise um, their use of that tool. So um, yeah, hospital-wide committee too. One thing you mentioned also that made me think a little bit was the reference to working with across departments. So like that interdepartmental cooperative venture. I've been at places sometimes where it can be a little territorial with some of that stuff, and like especially with cardiology and radiology, sometimes they don't want us to do the stuff that they do, which I sort of get, but yeah, that buy-in across departments is so important, especially for pushing it with the institution. Cool. Val, do you want to go next? Talk to us about what you guys are doing at NYU.
Sure. Thank you. And thank you guys for organizing this discussion. I'm a pediatric hospitalist, and I will talk about our elective rotation that we offer for pediatric residents. And it was designed with specific for specific environment for pediatric wards and for ICU. And it's in its original form in my previous institution, it was me and a PICU attending colleague who was also a POCUS enthusiast. So in the end, the application that we just selected based on the experience and what we thought would be applicable for hospitalists and for ICU attendings and for residents going through these rotations is generally aligned with what is in the work now as far as the budding PHM curriculum. So as an elective rotation, we offer it 3 times per year, and we take up to 3 residents. So 9 residents can take it in theory per year. Here at NYU program is it's 10 to 12 residents per year. So not the entire class that it's open to, but many residents, and especially those whose career path are through emergency medicine, PICU or NICU, would do that. I don't have slides, but I can try to share the curriculum that we have. Are you guys able to see it? Okay.
Yes. Yep.
So that's the way that I wrote it for a residency program. And by the way, it was very easy to get off the ground. They were very understanding. They just wanted something in a format that looks like a legit rotation curriculum. So that's why it's like mapped to KSA domains and to relevant EPAs for hospital medicine. And then the applications are heart, lung. Let's see, sorry. I have the list down here. Yeah, so lungs, I think we really focus the most, biggest bang for the buck on inpatient wards in ICU. And cardiac, IVC, skin, soft tissue, and then peripheral IV placement, urinary bladder, and LP. Also look at these applications. We teach them gallbladder, kidneys. We look at infant hips. It's just my personal little favorite here. I really like eye ultrasound. And it's also part of the rotation. So at this time, answering the question who we think comfortable as teachers. So it was a small group of founding parents of the pediatric POCUS committee. So it's my colleagues from ICU, PICU, NICU, cardiac ICU, and me. And when we created this POCUS committee and the POCUS credentialing pathway for the department, which is part of the wider institutional pathway that was already in place when we conceived this work, and we grandfathered ourselves and all others. So newer faculty who are interested to go through it, they would have to go through this credentialing pathway, which includes taking a POCUS course, either our institutional or elsewhere, and then submitting a number of scans in each application for review. And by the way, it's not part of the discussion, but what we're discovering, those suggested standards that were developed within emergency medicine, and most of the applications call for 25 scans. I don't think it really working for the wards. So we'll maybe have to rework it. The structure is flipped classroom. We have one day at the sim center where we practice LPs, peripheral IVs, and central line placement. All other days we come to the ward. So we have two major hospitals with large active inpatient wards and the ICUs and NICUs. And the residents are expected to come in the morning prepared. So they have reading assignments. They are emailed a list of recommended, it's mostly viewing. It's not so much reading, but looking at the videos. And they have to go around and find volunteers for us to scan. It's never really a problem. We can always find patients of necessary age and have good scanning models. So we first go over the didactics, and it's very brief. It's just probing the key points of the whatever applications we're looking for the day, and we go day by day from lung to cardiac / IVC, then skin, soft tissue, then we have gallbladder combined with infant hip, etc. And then we go and scan together before lunch. And after lunch, they either have clinic, they have their academic half day, they go to ED, and we have some of our great PAM faculty who agreed to help with managing this rotation, and they can scan with ED fellows and or ED attendings. Or they have independent scanning time. So they're expected to take the machine, go back to the ward, find either new volunteers or go back to the same patients and ask them again if they can scan them again and practice the same applications that we reviewed earlier in the day. The question was also in the email, how do we decide which residents get it? And I think both right now and in my previous institution, I just outsourced it to chief residents and let chiefs decide. And what I found at my previous institution, it was very easy. Rotation would fill up right away. Once you send the dates, you already have the residents who are ready, and some people are on a waiting list. And again, I don't manage who gets in or who doesn't get in. It's all in the hands of the chiefs. Here, I'm finding that it's actually difficult. I guess the way residence master schedules work are different from program to program. So some rotations we were not able to fill, and some we had to cancel because there were no residents who, not that they were not interested, but their schedules seemed to be a lot more rigid, and they just couldn't fit in with their other required rotations and other electives. Are there any other questions? Let me see in the list of questions in the email. So as I said, justifying it to residency program was very easy. I think they were actually very appreciative. Prior to this, emergency medicine were taking 1 to 2 residents, pediatric residents per year. And in fact, that was my main motivator to start this rotation in the first place. I went to ED colleagues and asked them if they're able to accommodate pediatric residents, and both here at NYU and the place I worked before, the answer was no, we just don't have bandwidth. We have to train residents and PAM fellow, and there's not enough resources, not enough space and time for pediatric residents. So there was, in short, there was an understanding on the part of the residency program that it is important skill and it's sought by residents. And the scans that residents do on their own time, they know that it's an expectation that the very last day of the rotation, we sit down and we go to the machine and open it and go through the scans that they've done. So they save it with the patient information. Those are all teaching scans, so they are not connected to the EMR, and then we review them together. Happy to answer any questions.
Before we jump over to Kevin in South Carolina, Julia asked a good question in the chat. For programs who offer electives, do you offer any kind of special certificate or pathway? So, much like we have like hospitals pathways or medical education or research or global health pathways. Is there, do any of your institutions offer something similar for POCUS?
We don't. It's just learning the basic skills that would help mostly people going into fellowships where POCUS is heavily utilized.
Yeah, we don't offer a certificate, but they can mention that they took a special elective that sort of prepped them for, especially if they're interested in going into a certain field, which I think adds potentially.
Yeah, same. We don't do a specific certificate.
We are starting to track each resident's performance clinically of how many scans they do, but I've never had a Peds resident ask me for their numbers yet. So I'm not sure, like maybe a PICU applicant or something like that, or EM applicant, but haven't had that yet.
We
Yeah.
do offer a credentialing pathway, but surprise, surprise, no one has tried to complete it or take us up on it yet, which is, I would have done it in a heartbeat.
We've had a couple of residents do the Society for Hospital Medicine certificate, and it's a hard thing to complete as a resident. It's expensive for one, and it's also pretty time consuming. You have to attend a few courses and save a lot of images. But we've had at least two in the couple years that I've been at the University of Minnesota who have completed it. And then we just started an elective here that's more asynchronous, and it's basically just a 2-week opportunity for residents to get their numbers up and like scan. And I use sonoclipshare.com for that. It's a free like online image storage or database thing where you can designate who to share images with, and then I provide feedback to the residents on the images they obtained. So you just have to kind of go through the workflow a time or two to figure out how you can save them to like a USB or something, and then upload them to SonoClipShare. Kevin, you want to talk more about what you guys do at South Carolina?
Yeah, I will be quick too, because I know people probably have lots of questions. So I'm Kevin. I'm a Peds hospitalist, Prisma Health, University of South Carolina. I have been here almost a year now. I joined Dr. Norton, who's on service with me, couldn't be here today. He's the one who started all of this. So I take no credit. I just jumped in and joined what he already had started. But we offer during our second year Peds residents get a week with us. Specifically, priority goes to the ones that are doing fellowship inpatient, so PEM, PICU, NICU, PHM, and they get a week with us one-on-one. So we go to the SIM Center. We have an ultrasound institute with USC School of Medicine, which is unfair but super cool. So they spend one day in SIM with just us, and so we work on cardiac, lung, fast, abdomen, skin and soft tissue, and some procedural, so that they get kind of all the knobology and kind of hand-eye coordination. And then the rest of the week is spent in the hospital, just clinically, wherever applicable, doing scans for people, which Dr. Norton and I are both credentialed. So one, we can bill, but we can also teach. So they spend the rest of the time on the inpatient service, scanning people, whether it's lung, soft tissue, LPs, PIVs, focused cardiac, basically kind of some of the basic core to PHM. I know there's not really a core, but what the literature does talk about. So they get that 1 week. And then for those that are more interested in their third year, they're allowed to sign up for a 1-month elective. And that elective actually will involve nephrology. We have nephrologists who do their own ultrasound in clinic themselves. A rheumatologist does their own joints. And then they will spend time with the echo tech and then cardiology reviewing echoes as it pertains to focused cardiac POCUS, so the 4 main views. They'll spend time with us mostly on PHM, and again, that'll be procedural, lung, cardiac, skin and soft tissue, lumbar punctures, and then they'll also go to the PICU and spend time with our intensivists. So we have quite a few intensivists who are trained in ultrasound, so that'll be later on with that 1 month, and that's really it in a quick nutshell. Dr. Norton was trained here. He did POCUS fellowship, so he has that 1-year fellowship under his belt. I sought out tons of training during PHM fellowship and residency, mostly from PEM, EM, NICU, and PICU providers. So thank you to all of you for sharing your wealth. And then Aaron can comment on this in and out, but I am pretty much done with the SHM cert, which was part of my fellowship training. So I just have to test out, but it helped a lot with image portfolio building, which allowed me to get credentialed at my current job here. Happy to talk on that as well.
Awesome. Yeah, I think the certificate is challenging, but it also sort of pushes you quite a bit to get your numbers up, and because you're spending so much money on it, I think also it like motivates you to finish it.
Yeah, put it. My colleagues got masters, and I got the SHM cert instead. And I will comment, Amanda, Julia, Aaron, like listening to your presentations, I was like texting Duncan, and I'm like, we need to do this, we need to do this, we need to do this. So thank you. Even though we have something, I'm taking little bits and pieces, and I will give you all credit.
Yeah, I've gotten so many ideas already from everything folks have shared. I did want to get back to Aaron. You guys talked about your gel rounds that you guys do. Do you ever have, and Val, you mentioned that you guys don't really have trouble finding patients to scan in the hospital, but I just wondered if you ever have trouble sort of drumming up business, or sometimes when I'm asking for patients for the residents to scan, it requires a little bit of education to the people I'm asking, where I'm like, I don't need them to have interesting pathology, or we just need like bodies. Is there like somebody who's like nice and bored or something? So I don't know if you guys have run into those issues, just like opportunities for them to scan in the hospital.
Yeah, I feel like it's very variable. Sometimes we'll have, and some of it seems to be like the residents who are on the elective at that time are really good at bothering their colleagues to give them consults. And so we might have like 6 to 8 in a day, or we might not have any. And so what we do then is and our elective, I didn't mention, is for pediatric residents and internal medicine, med peds, and family medicine. So we have consults coming from all of those different services. Sometimes we'll do a lot of pediatric consults. If they do not get consults, what we've told them tell them to do is go to the ICUs. Usually if you show up with an ultrasound and say, do you have anybody we can scan? They'll come up with like multiple patients that are good to go scan, or they're like, we wanted to go do a DVT study on this patient, can you go do it? So that's one strategy. The other is for our procedure team, we have a dedicated procedure team, and a lot of times they'll get consulted for doing paracenteses or thoras, et cetera, on patients that we suspect might not have fluid. And so the procedure attending or the residents will directly call the POCUS team and say, hey, can you go do a fluid search? And then that'll give the POCUS residents time to do like a very comprehensive abdominal ultrasound or lung ultrasound. And so we're pretty successful in that way in finding patients. But yeah, sometimes for whatever reason, we don't get any. And then sometimes we get tons and tons, and we're there for a while.
I like the idea of approaching the elective as a consult service, because I think that teaching that clinical integration piece is often the most challenging for the residents. Like, I think they can get pretty good at obtaining images in most people in short order, but then it's the like, how do you use that to critically inform your care of patients? Cool.
And I think we've had like there's been a lot of cases over the years where there have been some like huge wins for the teams that we were consulted for, and I think that often will really help get the residents more excited about continuing to learn more. And so I think that's really helpful to see real and apply to real patient care, how it can be helpful.
We don't have consult service, so as Scott mentioned, we're just looking for someone who is there, who's bored, and who would cooperate, for flipping the tragic scenario into a positive one for the purposes of learning POCUS when we had like a peak of the eating disorder epidemic. So those patients are usually agreeable to their adolescents, they're bored, and they would agree to have various scans. So it would go sometimes every day, same patient, scan in different system. But also, we've been doing it for many years now. There's awareness, the entire hospitalist group, that when we have this rotation and there are residents going around with the machine, if they have something interesting or if they have just just a question, so we get invited to look at some pathology.
In the emergency department, it's a little easier because it's like so condensed, if you will. And sometimes those EM residents are so busy as well that they're like, oh, could you go look at this guy's lungs for pneumonia? Or, you know, they kind of task you, but it's helpful because a fair amount of those scans will be clinically indicated, and maybe we'll find some pathology as well.
I know everybody kind of touched on the infrastructure available to them, but I wonder if maybe a few of you could touch on the conversations you've had around what sorts of machines to encourage, what you've tried as far as like handhelds versus cart-based, and sort of where you're at now with all of that.
So I started this program, and I used to beg GE to send me every month 2 of their like laptop based Logic E machines. So literally I'd go to the loading dock once a month, get the machines, have them in for that session, and send them out the next that night. Very unsustainable, but it was the best thing I could do because I couldn't take the clinical machines to do this off, you know, out of the ED. And then during COVID, we were able to barter with the Peds Residency to buy 6 butterflies. So that's when we had smaller groups, and we actually had to do all remote education, where we did it all via their tele butterfly system, and all the residents were at home and scanning themselves during COVID. And now we do in the classroom didactics, we still use the butterflies, but we definitely are challenged by image quality, cardiac especially, I would say, and sometimes soft tissue. And now with the third day of the intern curriculum, we're going into the emergency department, which we have just started doing that, but session 1 is done as of 2 days ago. And I think it's helping because they know how to use the clinical machines now. Now they're exposed to a multitude of probes. They know how to like record a scan, that kind of thing. So I think that's going to help. And the image quality is just so much better. But I think the jury's still out on whether the residents see it as valuable.
Yeah, we're a bigger site than Denver Health, so we have 3 machines dedicated to like the emergency department, and then we actually have 1 nursing machine, and then we have a vascular team. So we have a lot of machines, and then the hospitalist just has handheld, but then like our PICU has multiple machines, and the NICU does too. And so when we teach, I usually just steal 1 to 2 from the department, and since I run that program, no one ever argues with me, I guess. So that helps.
We're lucky to have a machine, our own machine for pediatric inpatient unit, and then PICU and cardiac ICU that are 1 floor above, they also have their own machines. NICU have their own machine. In our second hospital, NICU has a machine, and then pediatric unit also has a simpler, older version. But it's card-based machine for each clinical area, so that's really helpful. And I think when you have a group of 3 residents standing around the bed, so for demonstration and learning that application together, it's probably better than a handheld, and we don't have access to handhelds anyway. None of us actually have handhelds.
We have 2 cart-based, and then we have 2 handheld on the way. We just got lucky with some funding. Some of that came from just throwing in easy wins, thinking from a hospital perspective. Dr. Norton brought to the hospital, literature on PIVs, using ultrasound for procedure, that's kind of headed towards the standard of care, and showing the hospital that how much they made by using ultrasound to do it, and that we could be ones there to credential, right? Nurses need credentialing every year to be signed off. And that was a big win for the department because they showed that they were losing somewhere between $500,000 to $1 million a year in PIVs alone. And that was enough for the department to really push for, a POCUS committee, credentialing pathways involving nursing in it. And it was a big buy-in.
That's also how we just got 6 brand new machines as of like 2 weeks ago for our hospital that we replaced after 5 years. And we actually literally showed them our billing. So we said, this is where we were, this is how we are. And then we said, this is what, so we actually showed that we paid for our machines in 5 years based on when we only had like 2, 3 faculty credentialed. And now we've credentialed 80% of our emergency faculty. And so that we were able to show that like, this is what it was when there were 3 faculty. Now we have like 30 faculty credentialed, so this is how much we could expect to make. And so that our hospital was like, no problem, we'll buy you new machines. I mean, it was much harder than that, but that's ultimately what happened.
I've gone down that road a few times too with the billing, and I think on the inpatient side it's a little bit less lucrative or less it's like more complicated because of like the way that they do it. And as far as I know, only allowed really to either charge a facility fee when we perform a POCUS exam, or you can bill for critical care time technically. So I know people have like kind of gotten around it by doing that, but I don't know if what's everybody else's those who work in the hospital. What's your experience with like trying to tackle it that way, justifying the cost of machines by virtue of like that additional revenue stream?
So for us, there was no factoring of revenue stream into the justification for purchasing machine. At the previous hospital where I worked, we were actually very successful obtaining funds through the residence union. It's CIR, so I know it's a national union that many residency program belong to. They have a fund allocation annually, which is called patient care trust fund. And as long as hospital is willing to pay 20% of the equipment cost, they would provide 80%. And we got not 1, 2 machines, one for inpatient unit and one for PICU. And that was a pretty small place. Here at NYU, several factors. One is that our floor sometimes PICU patients board there. So the justification was that you need that critical piece of equipment right there when you need it. And the second, which I think was more important, is that all nurses were going to learn ultrasound guided IV placement. And that would really push the needle to have the machine and have it at station on inpatient floor.
Well, I think there was one question. The chat has been very active, which is awesome. I'll save the chat and then try to go through it and make sure that everybody got their questions answered. There was one from Lubina up here. For those of you who have a longitudinal curriculum that includes all interns, how'd you justify to the residency program it's important for everyone to learn the skill? Her program has been on board with residents learning it, but are hesitant to take an academic half-day time to teach it to everyone.
I think we justified it that even though the residents may not be using this in their future career after the 3 years, it was essential to have these skills to use in our critical care and especially our emergency department regions, that we're readily using it at both institutions, probably even the NICU at the university, I'm assuming, which is the 3rd location, but that we're actively using these skills on shift. And when they're on shift, either as in any year of residency, they'll be expected to be at least learning these applications to function appropriately there. So they seem to buy in. And you know, what's funny, some of our genetics and Peds neuro residents are like some of the highest,
And those some of the best.
most interested. It's kind of funny. Like I expect them to check out, but during our sessions, I think especially the sessions where they scan each other, they get a little bit of familiarity and some confidence. So sometimes I think a given resident will, be a naysayer, but sometimes they get pretty engaged. I did have one other response to the Butterfly Academy too. I'm not sure who put that question in the chat, but we started using Flip Classroom, as you guys are using Erin as well. We started using it with our interns this year, using the Butterfly Academy, because you can use your educational dashboard and assign each resident pretty good high yield, basically application assignments, such as a POCUS lung, et cetera. So, and then you can track their performance over time and sort of trying to make sure they fulfill at least that basic education prior to our first session, so that it won't be totally totally sort of new information to them, that we can kind of hit the ground running with our cases and at least reinforce some of the things that are in those in those modules that they do prior to. So as part of our study that's ongoing, but trying to keep up on the residents and making sure they can actually do it prior to that first day is sort of an ongoing assessment.
Yeah, I help out with some undergraduate medical education, POCUS teaching, and one of our ED providers got this big grant to teach all of our rural primary care track students. So they all got a butterfly, and you know, there was variable amounts of uptake. Some of the students submit tons of scans for QA, and some not so many. But some of them would use that Butterfly Academy, and I think it was helpful as an adjunct, but I wouldn't depend on it to like train someone up. You really need someone there to mentor you, I think. And in lieu of that, it's a harder road, but it's doable through some of the remote programs like the certificate from SHM. So I think we'll kind of wrap up here. And yeah. Thanks so much to the panelists who came and shared what you guys are doing at your institutions. I think it was super helpful. I'm really grateful that we got to record it, and I will upload it to our YouTube channel where we had some didactic sessions, and then send out the link so that folks can rewatch it if they're interested. I'll also save this chat and just make sure that we answer everybody's questions. There's there's a feedback thing I wanted to share. If you guys would scan this QR code, if you want to provide feedback for the session, and then I can send that off for the folks that participated too, so that they can add it to their promotion packets or whatever they want to do with it, or their special positive reinforcement box, whatever it is.
Thank you so much. I got to run to POCUS Didactics, but I really appreciate being part of the group.
Yeah, thanks for the invitation.
Everyone,
Thanks so much.
thanks, bye.
Thanks, Scott.